welcome. I am Julia Grabowski, and this is our break shop. I should say where I'm from. I'm from Larry Children's Hospital. I run the colorectal center there, and I propose this break shop on updates for ovaries and fallopian tubes. So we could talk about a few things. The goals of this session are to give up-to-date, high-yield, evidence-based recommendations for the workup and management of ovarian and fallopian tube issues we commonly see. Most places do not have access to PAG, and even if you do, they're not available 24/7, so this is a way for us to get a little bit of information from our PAG friends here. Melissa and Dana, who can tell us their thoughts about ovarian and fallopian tubes, and then we can give you some guidelines and algorithms to take home for use on the job. At the end of the talk, there's going to be slides that you can take pictures of, or you please feel free to email me, and my email will be at the end, and I can send you the slides myself. Also, please ask questions as we go. If you have any questions, stand up while we're going. We thought this was going to be like a really small group in like a small room, and we were just going to be like at a table. Now we're in a ballroom, so we do want like some interaction. Yell out if you have a question. Please go up to as we go and interrupt and ask questions so that this can be very interactive. Okay. So I'm just going to go through a couple scenarios, several scenarios, and I'm going to ask questions that I have as a person who takes care of ovaries and maybe sometimes doesn't know exactly the right things to do. And what I learned 10 years ago is probably not what we're doing in the year 2024. So here we go. Do you guys want to introduce yourselves, by the way?
Okay, yeah. Hi, everybody. I'm Dana Alborno.
Please get closer.
Okay.
Are you on?
Hello? Am I on?
You get to push it.
Hello?
Yeah.
Okay, cool. I'm Dana Alborno. I'm a pediatric and adolescent gynecologist, and I work with Julia Grabowski at Lurie Children's, and I also work at Northwestern Memorial in Chicago.
Hi there. I'm Melissa Parks. I apologize for my voice. I'm getting over laryngitis, so hopefully it will get me through this presentation today. But I'm a pediatric and adolescent gynecologist at Phoenix Children's Hospital.
I'm Marisa Schwab. I'm a pediatric surgery fellow. I'm very excited to learn more about ovaries and tubes today.
Right? Who isn't? Okay. Dana, are you first? Okay. Here we are in the emergency room with a 14-year-old postmenarchal patient. She is coming to the hospital. She's had a 24-hour history of vague abdominal pain. You see this ultrasound, which shows a 5-centimeter unilocular ovarian cyst. When we're called, she has had some Tylenol and Toradol, and she's feeling good. Her abdominal exam is benign. She's still having like some mild tenderness. Do you need to do any labs?
No. No. Oh. I'm going to get used to this. You do not need any labs.
Okay. Do I need to do any cross-sectional imaging?
No cross-sectional imaging.
Okay. Can she be discharged?
So in this particular situation,
5 centimeters.
yeah. So it's 5 centimeters, it's unilocular, and it's anechoic. So this is benign, looks benign, is going to act benign. So this is really a situation where we can't tell if it's physiologic or neoplastic just by appearance, and this very well may resolve on its own. So it's just a matter of shared decision-making, of talking to the family and saying, this will probably resolve on its own with repeat imaging. If she is in pain and we're concerned about torsion risk and she should be discharged with torsion precautions, you know, we can obviously monitor it and see what happens. If you're very concerned about a possible readmission and surgery, then we can operate on this today. In most case scenarios, patients in this situation would favor going home with monitoring and torsion precautions.
Okay, now it's 8.5 centimeters.
Same exact thing.
No labs?
No labs, no imaging on the time of diagnosis. If at time of follow-up, 6 to 8 weeks later, the cyst is persistent, then at that time I would do tumor markers and cross-sectional imaging.
Here comes Tim.
Hi, Tim.
It's on already. So an 8.5 centimeter cyst, do we have data on if those actually go away? Because that's not really physiologic at that point.
It still can be physiologic. Up to 10 centimeters, you can still have a physiologic follicular cyst. It's not necessarily a serous cyst adenoma. We do have studies in our literature that show that those still may resolve on their own.
Okay, when you say torsion precautions, what do you tell patients?
If you have 10 out of 10 pain and you're doubled over, you need to come back to the hospital.
What if they want to play gymnastics or do gymnastics? You don't play gymnastics.
This is, and I would be interested to see what Melissa says, but this is really where I don't think we have a lot of data to show what can cause a torsion event. A lot of times these events wake people up when they're sleeping. I don't think going back to school and doing gym and living their life will necessarily increase the risk of it torsing, but I say no roller coasters because I've taken care of a lot of torsions after a day at the amusement park.
What about a water park?
No.
Okay. Okay, now it's 6 centimeters, and on imaging, they say it's a hemorrhagic cyst.
Surgery is not a solution for hemorrhagic cysts unless they're hemodynamically unstable and have hemoperitoneum. They're failing to stabilize with like TXA and products. How I describe a hemorrhagic cyst is that it's a bruise on the ovary that has occurred from an ovulation event where after a mature follicle has ovulated, it tore into a small blood vessel and now you're bleeding into your ovary. Just like any other ecchymosis, it's going to take time to resolve and it's going to be painful. I do not think that replacing that hemorrhagic cyst pain with surgical pain is the right answer, and in the meantime you would also be causing some degree of follicular and ovarian damage, so leave it alone.
Okay, so they're saying like it really, really hurts, but it's 6 centimeters in hemorrhagic cyst. I shouldn't take them to the OR.
You should give them anti-inflammatories and a lot like TLC.
Okay, I'll do it.
I don't know if you want us to jump in this
Yes,
right
I
now.
do. Yes, I do. Please.
So I'm always scared of these because I'm like, how do I know it's not torsion? So how do I know?
So hemorrhagic cysts, we call them the great imitators because they really can present like appendicitis or torsion. I think my threshold is how do they respond to pain medication in the OR and what does the imaging look like? Yeah. What does the imaging look like? Because hemorrhagic cysts have very classic characteristic imaging findings. Reticular, retracting clot, and it's all of a sudden pain, and the way it looks on imaging, plus their abdominal exam, and how they respond to pain medications, all of the puzzle pieces together, I'm like, this is a hemorrhagic cyst. If they have peritoneal signs in the ER, then yeah, it may be a torsion, and you may end up putting a scope in and looking. And if you find that it's a hemorrhagic cyst, you're gonna leave it alone.
We're going to leave it alone.
You're gonna leave it alone.
Okay.
I'm Farouki from North Carolina.
Hi.
Hi.
What if you see this incidentally at appendectomy? It's a 5 centimeter cyst. Will you leave it alone?
Incidentally, like you didn't know about it on your preoperative imaging?
We generally do ultrasonography before appendectomy, or sometime not even. Based on clinical, I take the patient for laparoscopic appendectomy. I see a 5 centimeter cyst. Will you leave it alone or will you take it out?
So I think it would be hard to say with an incidentally found at the time of surgery the exact size of it and the characteristics. So I wouldn't touch it because you don't know if it's solid, if it's cystic, what the inside of it looks like. I wouldn't poke it until you know more about the cyst. If you know on preoperative imaging it's unilocular and anechoic at 5 centimeters, then it's shared decision making. Should we do something about it or leave it alone? If you're taking them back for an appy, that's the source of their pain, I would argue leave that cyst alone, it'll probably resolve on its own.
Okay, what about OCPs? Kid has a cyst, you either do something or don't do something, but they're thinking, should I get oral contraceptives?
So oral contraceptives stop the development and maturation of ovarian follicles. So they do not prevent neoplastic cysts like serous adenomas or dermoids or other types of neoplasms, but they do prevent follicular cysts and hemorrhagic cysts. So I would say that after a single episode of a follicular cyst or a hemorrhagic cyst, I don't feel strongly about putting somebody on a daily medication. If they have an issue with recurrent cysts, I would say combined hormonal contraceptives make sense. I would favor a monophasic combined hormonal contraceptive that has at least 30 micrograms of ethinyl estradiol. I think the role of it can only help you in monitoring if you want to prevent new cyst formation and just clarify the picture of am I looking at a new cyst or is this the old cyst? So, and occasionally in situations where it's like 5-6 centimeters and I'm doing a monitoring protocol, then I'll start them on it until we get their repeat imaging.
Okay, oh, first I have another question.
Okay.
Let's say you do a cystectomy and it comes back as a serous adenoma.
Yeah,
Then what am I doing for follow-up?
nothing. Nothing?
No, it's true.
I'm like,
I just heard the murmurs.
I'm like the looks in the crowd, I'm like, nothing,
Okay,
right?
so see, what if it's mucinous?
So for mucinous, I would say slightly higher risk of recurrence, worthwhile to repeat imaging in about 6 to 12 months.
Ooh, okay. Now, this is a patient, the same patient, she's come in, you go to the OR and it's a paratubal cyst.
So paratubal cysts are the result of embryologic remnants of the Wolffian ducts. These are not going to go away on their own. So my size threshold to intervene is really the same as ovarian cysts, but I'm not really monitoring these in the same way, thinking they may resolve. So this isn't a situation where you're like, oh, this is probably going to go away on follow-up imaging. This is more so a situation of you have this thing, you're going to continue to have this thing. If it doesn't cause you problems, we can leave it alone. And if it causes you problems, or if it's likely to cause you problems or it's greater than 6 centimeters, we can take it out.
Okay. Here we have,
Can I ask a quick question?
of course, please do.
Paratubal cyst, what's the function of that tube?
So the tube's good. Leave the tube alone. It's not a problem. Paratubal cysts are more common in women who have hyperandrogenism or irregular periods, obesity, insulin resistance. We think there may be something in that trifecta that causes these embryologic remnants to develop more fluid. But the tube itself is functional and normal, and you should not take out a tube when you're removing a paratubal cyst.
And so, sorry, if the patient is symptomatic with a paratubal cyst, it doesn't matter the size, you're taking it out?
Yes, but I think I would have a hard time believing it was causing their pain if it was like 3 centimeters.
I was going to say, like, the little, like, Ditzel 1-2 centimeters, and nobody can find anything else on imaging, but this little thing, it's not causing pain. Most often, it's not the source of the pain.
Yeah, hi.
Hi. So last month I had a kid just like this paratubal cyst, but it came with a torsed tube.
We see
So
this.
what would your approach be there?
So paratubal cysts can cause isolated tubal torsion, and it's a harder torsion to diagnose because it's not quite as symptomatic. That's why over 5-6 centimeters, I think it's super reasonable to remove them to prevent tubal torsion. And if you find it at the time that it's torsed, you should still make an incision on the mesosalpinx and nucleate the paratubal cyst after detorsing the tube and leave the tube alone, as long as the tube is not like falling apart in your hands. It's gonna look bruised and it's gonna look ugly, but it's gonna heal. I would say have a really like high threshold to remove the tube.
High? Oh, yeah, okay,
Yeah.
high threshold. Okay, don't remove the tube.
Try not to remove
And
the tube.
we talked a lot about this, and like we sort of thought, or I was taught that if the tube looks really icky, like maybe you're putting them at a higher risk of having ectopic pregnancy or fertility issues in the future. But as we've discussed, that is not necessarily true.
Yeah, and we'll talk more about that when we get to the hydrosalpinx.
Oh, can't wait.
So yeah,
Can't wait. Okay.
it's coming.
We've got something over here. Yes.
Yeah, you mentioned obesity and irregular periods with paratubal cysts are more common. How often would you recommend screening them for PCOS afterwards?
Oh, such a good question. And yeah, I think it's if you have a patient that has hyperandrogenism clinically with acne that's refractory, has abnormal hair growth, and also has irregular periods, typically infrequent, heavy, and prolonged, that's absolutely needs screening for PCOS, paratubal cyst or not.
Okay, moving on. Next patient is a 15-year-old postmenstrual patient. She comes to clinic, she presents to clinic. She was like feeling a little bit distended. She didn't really have much pain, but maybe she's like couldn't fit her jeans on quite as well. And she had a little bit of bloating, and CT was done that looks like this. Tim, I think this was your patient. Okay, everyone stay calm. Okay, Melissa, any labs?
These are my favorite cases, by the way.
Are you
so,
on? Oh, yeah, you're on. Okay.
Yes. Sorry.
Melissa's favorite cases.
I can't project as I normally do. I apologize.
Giant ovarian cysts.
I love giant ovarian cysts. So, I mean, first, looking back at that CT, the image appears that it looks very simple in nature. The thing that's most concerning is the size. And, you know, the size is what's conferring the malignancy risk here. So for me, I'm absolutely going to get tumor markers as a panel, not as like individual selected tumor markers. So
What is your panel?
Sorry, exactly. So my panel is typically LDH, alpha-fetoprotein, HCG, CA125, and then inhibin A and B. I don't typically do like a CA19-9 or a CEA, just because the data doesn't typically support use of those and predicting malignancies in this population. For her, after we would, I would get the labs, and then as far as like, what am I going to do next?
Yes. Can you save that ovary?
You can definitely save this ovary.
Okay, tell us how you're going to save that ovary.
Yeah. So, assuming that our tumor panel markers are all completely normal, my favorite thing to do. Do you want me to pause first, or do you want to ask your question?
No, go ahead.
How I like to do this is I do a 4-centimeter vein and steel incision. Usually the cyst, that's something that's that large, is going to be right at your incision site. And I use a gallbladder trocar to decompress the cyst. And it's really great because it helps to minimize any kind of spillage. You can do like a little purse string suture first, like just in like the ovarian cortex, to kind of bring it up to your incision, pop through the gallbladder trocar, decompress it, completely exteriorize the adnexa, and then you can do your cystectomy outside of the body and you completely spare the ovary and the tube.
Timothy?
In my experience, when they're this big, you get the panel and the CA-125 is like 2 times normal. It's like slightly elevated just because of the size of the serous cystadenoma, which this is. Is there a threshold of CA-125 that you can be comfortable with in these patients?
I don't know that I have a specific threshold. If the imaging is like there are no other concerning radiographic features, there's no mural nodule, there's no septations, there's no internal blood flow, there's no, solid components, and your CA-125 is just a little bit elevated, I still would do the same procedure. The main thing is just you're concerned about spillage, right? And like up, going from like a 1A to a 1C for your staging. But if you're very careful, you really can do that without spillage. There is, I've done this a couple of times. I did it with some of the gynocs when I was a resident, and then I've done it in my own patients as well. If you can get the cyst surface really dry, you can get like a big piece of tegaderm, and you can like smack it on the cyst surface, and so it's nice and adherent, and then pop it through. So if there's spillage, it's spilling like on top of the tegaderm, and you can have suction ready at that time. And then again, it's just like another way to decompress it.
I think some of us sold Dermabond,
or
like ultrasound
bag. Yeah. It's great. So you can do that.
And then what happens? Sorry.
I was just gonna say, and then like after, if you, we're gonna talk about it, I think, in another case. But I really trust our pathologists at our institution. I've had really great experiences with them. So if like you're really concerned, you can do frozen. Now for the really large cysts, there is limitations in missing. Like if it's like a borderline or a mucinous, there is like you're decreasing the accuracy of your frozen. So, but there are kinds of, there's different kinds of scenarios and like how that you can intraoperatively make a decision about sparing the ovary versus taking the ovary. But generally speaking, you can spare the ovary.
And what if you're draining and it's leaking a little bit of fluid and it looks mucinous? How scared should you be?
That's different.
A little bit scared?
I'm a little bit scared.
Okay.
Yeah.
Yeah, question?
Hi, I'm Cassie. I'm a fellow from CHLA.
Hey.
So I think you might have touched on the answer to my question, but in these cases where it's a very large cyst, but our markers, not all of our markers are done in-house, and so some of them are send-outs, including the CA-125. Would we just utilize those high risks, such as mural nodules, to dictate whether or not we spare the ovary?
Yeah, and in this patient in particular, she didn't really even have pain.
Yeah.
I think everybody was ringing alarms because they were like, look at this giant cyst, but it's probably been there and she's probably been functioning for quite some time. So if you have the capability to wait, as long as it's not going to be an unreasonable amount of time, you can wait if you would like. Like at our hospital, the inhibins take forever. But like really you're only looking for elevated inhibins if you suspect a granulosa cell tumor. That's going to be like based off of your clinical exam findings. Like actually had a case recently where it was a 10-year-old who she had breast development, but she has like super short stature. She still looks like pre-pubertal. She looks like a child. She's intermittently having bleeding, and by the way, she's got a mass in her abdomen. I'm like, yeah, I'm gonna wait for the inhibins to come back in her estradiol, and I'm pretty sure it's a granulosa cell tumor. But like, if like say she's coming through the ER and she's having a lot of pain, and I'm not gonna sit on the inhibins. But like, so you can kind of like risk stratify and determine what you want to do based off of like the clinical presentation.
And I think that's also shared decision making, right? Of like being really transparent with the family about this is what I think it is, and that's how I'm going to act. And there's a small chance I'm wrong, and if I'm wrong, we will have to come back for a second surgery. But to me, and this is something I say all the time, it's just as negative of an outcome to take a normal ovary and to over-treat benign and physiologic pathology than it is to leave in a premalignancy or malignancy. So I think that we really have to think about taking the ovary as being a bad outcome when we didn't need to. And I'm very transparent with the family about that. And I've had some people come back and say, we don't want any chance that this is potentially borderline and leaving it in place. And we understand based on your risk stratification, it's less than 1%. And I talk them through all my tables and my risk, my predictive models. And they say, no, we want to take it out. And that's okay too. But that's the minority of people who are looking at a 12-year-old who has years of reproductive and fertility potential and hormonal production ahead of her. We need to try to save her ovaries.
And like, I don't know, like losing an ovary, it's not like you lose a spare. Like it actually has some like long-term implications of like early menopause and, like just decreased fertility. So while that one ovary does compensate and they generally speaking will have a fairly normal reproductive life, there's also a good chance that they won't. And we're making that decision at such a young age. And so it really does have like pros and cons to each side, so.
Another question?
Yeah, hi, Andrew Zegman from Portland, Oregon.
Hi.
With the tumor marker business, we send off our panel, all that you described, and the inhibin A comes back pretty quickly. Inhibin B takes a long time to come back. I don't know if it goes to Kazakhstan or something. It just takes a long time to come back. What is the incremental value of waiting for the B, of the inhibin B?
I mean, I think if one is normal, and again, you don't have a clinical picture that makes you worried about some sort of granulosa cell tumor or Sertoli-Leydig cell tumor, I think you're fine. But again, shared decision making of like, I don't have everything back right now, but this is what I'm seeing. Given your picture, given your imaging findings, given what this tumor panel markers are showing, I think you're, this is a benign lesion, then sure you can proceed if everybody feels comfortable.
And it's typically the inhibin B actually that's elevated in granulosa cell tumors, not the A.
Thank you.
So there's slightly different subtypes, and the B is what's more likely to be elevated.
Oh, great.
So, it just depends on your level of clinical suspicion.
Great, thank you.
Hi, thank you so much for this panel. My name is Barry Rich, I'm from New York. I have a comment and a question. The comment is some rare, but not impossible for a granulosa cell to not have any virilization or not have any symptoms. So I would just advise caution because that's not always the case. And also we've seen where they are called like a mimicker or even the adult granulosa cells where they can look like a simple cyst without any symptoms. And then my question is about the borderline. And I know there's data about ovarian salvage in borderline as well. And just monitoring with surveillance. So I'm curious about your thoughts about that. Because someone had mentioned removal of the ovary for even the borderline tumors, but I think there is some data to suggest we can do just cystectomy. Thank you so much.
Of course. To kind of just comment on your comment, I think that we can't, while we know that these rare things can happen, like cervical cancer in a 19-year-old, the recommendation is screening at the age of 21. Like we have these rare incidences that happen, but we can't always practice in such a manner. So
I agree. I wasn't
yeah.
advocating for ovarectomy. I just think that it can happen, and, and those are the cases where you'd have to go back and, and do it.
Exactly. Like
just to be
you go back.
just caution, but I totally agree. I'm not advocating for ovarectomy. just a point that we've seen and has surprised us.
Yeah, and I think, and not to say that that's how you were practicing, it was just, but some people do actually practice in that manner where they kind of will, well, I'm gonna take out this big 15-centimeter cyst with the ovary because of this rare time that X, Y, and Z happened, but we know that we don't necessarily have to do that. For the borderline ovarian tumors, I actually have had, I don't know why I tracked a lot of them, but I've had a lot of them in my career. And some of them we had a somewhat of a suspicion for, and others we had no idea, and it looked like just some simple cyst, and oh, surprise, here's your pathology. And so if you follow the guidelines for surveillance, you have two options of ovarian sparing versus a salpingo oophorectomy. And I've had several successful surveillance of these kids with just CT scan and CA-125s over a 5-year period, and then they're clear. So you don't have to do a salpingo oophorectomy, and you don't have to feel like, oh gosh, I got this surprise pathology, and now I need to go back in for a second surgery to take that tube and ovary. You can just do surveillance and do so safely.
Marcus.
Hi.
Hi.
Thanks for this. This is awesome. I actually have 3 questions based on this
gosh.
case.
We do only have 16 minutes left and a lot more slides.
And I plan on taking all of them. No. So the first question, you mentioned early menopause. If you remove one ovary, how much earlier? Do we know? Is it a range?
We're seeing 40,
Yeah.
the natural age of menopause being 50, and anything abnormal would be before the age of 40, so prior to 40, so
Prior
like
to
a
40.
premature ovarian
Okay.
kind of setting.
Yeah, because I've always counseled them that, but I don't know how much earlier. And then about the actual technical aspects of the procedure, sometimes these are so expanded, these ovaries, that it's very hard to actually see any of the normal cortex. Any tips on sort of how to try to preserve ovary when you can't actually differentiate it from just the massive cyst?
How I usually will do is once I've decompressed and exteriorize, I just put 2 Alice clamps on, take a 15 blade and just almost like I'm scoring it. Mm-hmm. And then if you get some mosquitoes, you just kind of naturally find the plane. But it's like you're taking 2 pieces of tissue paper and you're separating them. So it's very, very delicate.
So is it along the entire outside of it?
Mm-hmm. Yeah. Mm-hmm.
Okay.
And you don't have to you can do it through a small incision. It's almost like you're inverting it out. Sometimes you kind of lose where you are, so whatever kind of incision you want. And you don't have to necessarily sew it back together. Just make sure that everything is hemostatic, but usually I will kind of do a couple purse string stitches sort of into just to kind of bring it down in. So it's not just this big, huge floppy thing that I'm putting back into
And
the
if you're
abdomen.
having a hard time finding the plane between the cortex and the cyst wall, you can ask for a dilute vasopressin, get 10 units mixed into 50 cc's of saline, and take a 10 cc syringe with a 22 gauge needle and inject it into that space that she's talking about finding with a mosquito, because it's sometimes easier to use a needle than it is to find it with a hemostat, and to create some tumescence and to create hydrodissection to separate the cyst wall from the ovarian cortex. Once you get it started, then it's super easy. Sure. But I think just sometimes initially finding that plane is a little bit challenging.
Great.
What's your
Great
third
tips.
question? Do you have a third question?
Yeah, I do.
Okay.
The fallopian tube is frequently splayed out and very, very sort of long.
Yeah.
And I leave them in, of course, but do we have any sense of how well they function? Are there any issues with those fallopian tubes after that?
I don't know that there's necessarily statistics on it, but just anecdotally speaking, most of the time they do just fine. And it's amazing how resilient the reproductive structures are with ovaries and tubes, that they're able to stretch to such large sizes, and then you go back in their abdomen for something later and everything looks completely normal, like nothing ever happened.
question?
Yeah, I was just going to comment on technique. I think the hydrodissection is a great trick. And where to start, where to look. Oftentimes it's just under the fimbria. It's, for whatever reason, that seems to be where there's a bit of a thicker plaque of tissue. And then you can kind of get into the plane right there where that plaque is and then kind of take it around from there. I don't know if you guys have seen anything different than that, but just a trick that I find helpful.
Yeah, I like going right near the uterovarian ligament because that's really where the cortex splays out. And then there's typically a separation between the cortex and the cyst wall right at the uterovarian ligament. And it's also nice to like stay away from the IP and stay away from the fallopian tube. And when you inject dilute vasopressin near the uterovarian, you're also decreasing your blood loss for the case. So I typically, if I'm close to that, like when we pull it out to enucleate it, if I can identify the uterovarian and I'm able to inject there, that's typically where I inject.
Okay, moving on. Got 11 minutes to do
Oh, gosh.
like 70 more slides. Okay, 16-year-old comes into the ED, has severe pain, you think it's torsion, simple cyst. I already know the answer to this. Urgency of the operation?
Within a couple hours.
Okay. Any workup?
No.
No, okay. Okay, we go to the OR and we see this. So torsion with a cyst that looks, I don't know, 7 centimeters. There's some blood in there, you suck it out. You untwist it, and then are you taking out that cyst?
Yes.
What if it's solid? There's a solid component that you saw instead of...
Oh, well, that's a different situation.
Well, I've changed it.
Okay, so if it was solid and then I'm counseling them like, hey, we need more time to do this workup, we're gonna go in and we're gonna untwist it, improve your pain, and then we're gonna wait for our tumor markers and imaging and plan your surgery.
Word, okay. That's what
And that's like a detorsion, you just need one, like camera port and then one other port. Unflip it and get out of there.
Okay, word, okay. Now you see this. I don't know if this comes off, but this is like, you're thinking like, shoot, this is
Really
like
bruised.
dead, real pretty, nasty looking.
Not dead.
But okay, you have untwisted it, and it looks like this.
Yeah.
Maybe 15 years ago, we would have done
An oophorectomy.
What are we doing in 2024?
So I did my fellowship research was about this scenario of like, can we do a cystectomy in this scenario? Are we affecting future follicular development? Like, what should we do when we think it looks dead? This is a scenario when I would leave it and I would try to save this ovary. I would make one small monopolar incision on the antimesenteric side. I'd put my little graspers in there. I'd see what the tissue integrity feels like. If it's falling apart, I stop. And I counsel them, you're gonna need to come back for a cystectomy once your tube and ovary have healed. And what we really benefit from that is like follow-up imaging. Did the cyst go away on its own? Is your ovary alive or dead? And if you need a second look laparoscopy, you need a second look laparoscopy.
Roger that. Okay, now we've got an 8-year-old. What's happening with her? Oh, she comes in with severe abdominal pain. You're worried, there's asymmetric ovaries, but they're not seeing cyst or mass, but you're worried about torsion. You go to the OR and you find torsion, but not in like a normally-ish looking over. I mean, maybe it's a little bit swollen, but there's not a cyst there. You untwist, and then do you do anything?
So, like, in terms of, like, should we do an oophoropexy, I think there's, like, a lot of different things to consider. I think, first off, if this is just, like, a one-time occurrence and you're not really seeing any other anatomic abnormalities, like, for example, like a very, like, lax uterovarian ligament or, like, very, like, long fallopian tubes, like something that would make you think like, oh, this might happen again, then you don't necessarily have to do anything. You just detorse it and we'll see what happens. The fact that she doesn't have any ovarian pathology is another risk factor for her for recurrence. But we also have to think about like if we do a pexy, does that guarantee she's not going to have a torsion again? No. There's still a 10 to 30% chance of torsion even after pexy. So, and there are also some long-term implications with it. So when you, depending on like what way you like to do your oophorepexies, you could be disrupting kind of like the anatomic association between the ovary and the fallopian tube, which again can impair future fertility. You could be disrupting the blood supply to the fallopian tube, again impairing future fertility. And then there's also some data that maybe they have chronic pain from the pexy itself. So I think like, you know, you have, as a parent, you're coming into the, I never want this happen to my kid again. I need you to guarantee this is gonna happen. I wanna do every intervention, but you have to make sure, again, a shared decision model, like
what is indicated.
So probably not the first time.
So not the first
maybe
time, probably on the second time. It happened
Probably
3
on
months
the third
later,
time. Okay.
again with no ovarian pathology. How do I do it? So we were just talking about this earlier. I have only actually had one patient in my career, I'm sure more are coming, that actually was a good candidate for this, and I do it to the ovarian, to the round ligament. You can also do a uterovarian plication, or you can do it to the sidewall.
And
then
use permanent suture.
I was just going to say, and then permanent suture. You
Okay.
can use absorbable, but
now,
permanent's better.
the mystery of all mysteries, hydrosalpinx.
Oh gosh.
15-year-old postmenopause patient coming to the ED. It's like maybe she has appendicitis, has some vague abdominal pain, but we see that there's a normal appendix, but she has hydrosalpinx seen on ultrasound. What other workup do we need?
Is she sexually active? Do
No.
I think this is pelvic inflammatory disease?
She's not sexually active.
Okay. If not sexually active, does she have a surgical abdomen?
No, no,
Okay.
no.
Then no further workup needed. I would start her. Oh, I would also ask her about her periods. Does she have a history of dysmenorrhea? Do I think this is happening in the setting of endometriosis? Also, in the setting of her surgical history, has she had prior surgeries that may have put her at risk of adhesions and inflammation and scarring? I'm trying to figure out why she has a hydrosalpinx. That's my line of thinking is,
Okay.
do I think you have endo? Do I think you have an infection? Do I think you have adhesions?
Okay.
If I think it's infectious or inflammatory from prior adhesions, I'm starting them on doxycycline. If I think it's happening in the setting of endometriosis, I'm starting them on OCPs, and I'm not operating.
Great. Is operation ever indicated? I know the answer because you told me
Yeah.
it's indicated when you're worried about tubal torsion.
Yeah, so if a surgical abdomen.
Okay. Number next. Okay.
Oh, and then also if, she, like, you had a case, tell them about your case.
Gosh. So I had a 17-year-old recently that had a chronic hydrosalpinx, and when I say chronic, she had it for 4 years. We've tried multiple courses of doxycycline. We had proven time in and out that this was not like pelvic inflammatory disease. It was not infectious in nature. We still, it's unclear what happened. Maybe she had PID at one point and it led to it. Regardless, she had this pain. And after discussing doing diagnostic laparoscopy with a salpingostomy and drainage versus a salpingectomy, she chose a salpingectomy, and unilateral. It's not something that I frequently do.
She's not proud of it,
I'm
but
not
I think
proud of it. I'm like, oh God.
But I think it's helpful to mention.
It can, I mean, and
There
when
is a
we
role
got
in some
in there,
situations.
there is a role in some situations.
So if it's chronic, no better cause for the pain. And then I would also say, like, in that situation, maybe she has like some congenital issue with draining that tube. Maybe there's congenital aplasia of a portion of her tube.
Okay.
And her other
Now
tube
you're in the
was fine.
OR with someone who has presumed appendicitis. You find the normal appendix, but then you find this hydrosalpinx. Let's first assume that this is, as it looks, like sort of inflammatory-ish and like maybe has some pus.
Yeah. So I do nothing in the OR. Okay. I get out of there and I start her on antibiotics.
Got it. Okay. What if it's not really purulent E, but just hydrosalpinx? You're going to also do nothing?
And like no evidence of endometriosis or otherwise, yeah, I'm still doing nothing.
Okay, we're still doing nothing.
Because a lot of these will resolve on their own.
Okay. Then do we need to do any follow-up? Like, is an ultrasound helpful?
Yeah, I think super helpful.
And what should I tell the family about like what that tube's going to do?
After one episode of PID, so like, right, we see this on the adult side a lot where we have like pelvic inflammatory disease, salpinx, there's like frank pus pouring out of the tubes, or they have a tubo-ovarian abscess that we do IR drainage, long-term antibiotics, and it heals. After one episode of PID or TOA, it's about a 4% risk of tubal factor infertility or ectopic pregnancies, and then after 3 episodes, it's about a 50-50 chance that you'll have tubal factor infertility or ectopic pregnancies. So I would extrapolate that data for this family and be like, it's not the exact same, but we think it's overall a low risk that this tube will not work in the future.
Okay, and if it's undergone torsion, we untwist it and leave it.
Untwist it and leave it.
Okay, and if there's pus, we're going to give antibiotics, but not drain it.
Not drain it.
Okay, roger. Okay. Now we're at a 15-year-old who comes in with a 4-centimeter, quote-unquote, ovarian mass, seen on ultrasound. She's asymptomatic, didn't know it was there, has mixed solid and cystic components. There's some calcifications. Look at this awesome cartoon.
It's beautiful.
Okay. Are labs needed?
No.
Whoa. Does she need a CT?
No.
Or MRI?
If you feel like, so if you are looking at the imaging and you and the radiologist feel very confident or feel, somewhat reassured that this is a mature cystic teratoma, so you're seeing like fat fluid levels, you're seeing echogenic dots and lines that, for the hair. If you think, this looks like a mature cystic teratoma, you do not need to do anything. She doesn't need an operation. You can give her torsion precautions, and you can repeat an ultrasound. And
when are you getting that ultrasound?
I usually will repeat it in 6 to 8 weeks, and here's the reason. I've had plenty of imaging. Most of it comes from outside where I don't actually have the images, and it's just a report, and I repeat it, and it's gone. And so it said, oh, it's a complex cyst, and it was actually just a hemorrhagic cyst. Okay. So basically you are, for a couple things, you're confirming the accuracy of what your diagnosis is, and then you're also reassessing, has there been any changes in the characteristics of this mass? Has there been growth? Is there findings on there that are changing your clinical picture to make you think maybe this is not a benign neoplasm and is actually maybe more concerning for malignancy? And if that's the case, then yeah, I'm gonna do cross-sectional imaging and I'm gonna get a tumor marker panel. Yeah. So if it's greater than 8 centimeters, that's my just general threshold for doing tumor markers and cross-sectional imaging.
Barry.
Hi, you answered my question. I got up prematurely. But I guess I would just say that there are a lot of mixed malignant germ cell tumors that have the components of mature teratoma, because there can be 50 to 80% that have components with mature teratoma. So just because it looks like mature teratoma on imaging, 3-dimensional or otherwise, I would have a low threshold to check tumor markers. I don't think there's too much of a downside. 4 centimeters, I agree. Yeah. That's small, but if it gets bigger, I would advise caution that it can be confounding. There can be mature teratoma components with teeth and hair and have small malignant foci or larger. So
follow-up imaging.
Yeah, follow-up imaging is important. And then that 5 to 8 centimeter is kind of my gray area too, but usually for sure 8 centimeters is my cutoff for doing a panel.
And you usually do cross-sectional imaging at 8 centimeters. Okay, we'll get to your algorithm too.
And then operative approach, I'm thinking this is benign, laparoscopic is great. If you have any concerns on your tumor markers, again, one of your tumor markers just a little bit elevated. One of the things that I like to do is I'll still do laparoscopic, but I'll put a bag underneath of it. So if there's any spillage that you are not getting that into the abdomen, and it's worked really beautifully before. And then as far as follow-up after you've done your resection, I usually will repeat imaging in 6 to 12 months.
Okay, so we're out of time, but I said that you could have some take-home points. So if you want to take pictures, take pictures. These are some rules that now I'm living by. So small physiologic cyst, no monitoring, no surgery if it's less than 3 centimeters. If it's asymptomatic up to 10 centimeters, you can follow up with an ultrasound, which is 10 centimeters seems very large to me, but I will learn. And OCPs are to prevent new cysts, not to deal with the cyst that's at hand. You can do laparoscopic cystectomy if they're persistent and greater than 5, or if greater than 8, then we're gonna start sending some tumor markers and do cross-sectional imaging. If it's persistent but small, but symptomatic, we should still take it out. Asymptomatic, you could just follow it. And then if you're following a symptomatic cyst, or if you meet a symptomatic cyst between 5 and 10, you can do nothing, but you can operate if they're having some stuff. We've looked at all of this stuff.
So that was that was just clarifying if it's unilocular, but it's not simple.
Oh, yes, Roger.
So if there's some echogenicity, there's maybe not a full septation, but a half septation. That's when you're really repeating your imaging more closely and monitoring, not in the same way that you would if it was unilocular and simple and 5 centimeters, you might not be repeating your imaging at that point, but when it has some complex feature, but not actually a full septation, that's when I watch it a little bit more closely.
Dermoid, we just talked about this. And then, ultrasound, we said within the first year. You said you usually 6 to 12 months?
6 to 12 months.
Okay.
It kind of just depends on the patient and where are they going to be in the next 6 to 12 months.
And then let's say after 6, you got their first ultrasound and there's nothing there. I feel like I'm just getting ultrasounds like forever of their
You don't
entire
have
life.
to.
I don't have
yeah,
to.
and
okay.
there's actually a really great paper in JPAG looking at surveillance of germoids and other benign ovarian lesions. And there's not like a benefit to doing routine surveillance like after cystectomy in these cases. And what it does do is increase your findings of new things and then repeat surgeries. And so doing it symptom-led is also appropriate. You do not have to have like a routine surveillance.
Okay, best practices at time of torsion, always untwist. Take out the cyst if you can see it and it looks like it's a simple cyst, but if you can't, then I mean, we have learned in this group that we used to all, if it was dead, we would like take it out. Now we're untwisting and coming back if we need to.
Yeah,
okay, great.
beautiful.
Okay, this is the Phoenix protocol. This is for ovarian masses seen that are small. So this is less than.
It's based off of the like the patient's age.
Yes.
Or like their pubertal. So if it's let's see, the first slide is small, right? Sorry. It's like
yeah, sorry.
So if it's
this is
a
small
small mass,
small.
less than 5 centimeters pre-pubertal, or less than 8 centimeters in pubertal, this is just kind of like it was a collaboration between Gyne, Gen Surg, radiology, and HEMONC. And just kind of like dictated our, ABSA actually has a practice committee publication about this as well.
Very similar, yeah. Okay, and then, and this is, it's a bit of a busy slide. This is the ORAD's sort of classification of high risk and low risk lesions, and I think just knowing that it's out there is really helpful. You can Google it to see if you're having questions about some of your imaging and how to counsel families on sort of their risk of doing nothing, doing something, and just giving them a little bit more clarity about how to risk stratify.
What I really like about it is that when we talk about, get an MRI and tumor markers, and then it's kind of like, okay, well, what now? I got my MRI, and now I have these findings on my MRI. How do I actually risk stratify my MRI findings to counsel the family on whether or not I'm doing cystectomy, oophorectomy, or getting, HEMONC involved or whatnot? So I feel like what's really nice about this is that you can have ORAD's 3 or 4 ultrasound findings, and then you get your MRI and it can downgrade you or upgrade you in terms of your risk of malignancy. So this is what I really use to help engage in that shared decision making after getting my MRI and tumor markers. If my tumor markers are normal and I'm really risk stratifying based on MRI findings, this is helping me give them a percentage risk of malignancy and using that to decide what to do next.
Is this just for kids, or is this the same thing used in adults?
It's adults.
It is adults, but I will say that in the PAG literature, we've now started including this and utilizing it, and it's something I would say is like very popular in our corner of the world.
Yeah, so far it's okay to extrapolate adult to
I would say into the post-pubertal patients, there's no problem with extrapolating. Mm-hmm. It might not be perfect in a premenarchal population, but it's still kind of like a rough and quick guide of like, how am I interpreting some of these MRI findings? And I also really like the language of what you're looking for on MRI. It gives you some very specific language of like diffuse weighted imaging findings. So I type those in for my radiologist to be like, please do the DWI and look for X, Y, and Z. So now my MRI reads are so much more detailed and helpful for me when I'm looking at adnexal masses.
Thank you. Okay, we're over, sorry. Oh, we have another question. Yeah, come on in.
So with simple cysts, looking at the diameter, shouldn't we be looking at ovarian volume as a risk factor rather than diameter?
You can definitely look at volume versus like your largest like dimension. I don't know that it would change my plan or like how I would approach it though.
There's something called the morphology index, which is validated in the pediatric adolescent gyne world for adnexal masses, and they do use volume. But it does shake out to end up being the same.
Mm-hmm. Sam?
Back to the infectious stuff, do you always send tubo-ovarian abscesses for drainage? I think that came up a couple times in my fellowship, whether you just do antibiotics or if there's a threshold to drain them.
Great question.
I usually do not. I do a trial of antibiotics first while they're in-house, and if there's no response in 72 hours, meaning that like pain is starting to improve, They're like, if they are like nausea, vomiting, not tolerating, a regular diet, they're still febrile, then that's when we are oftentimes consulting IR to discuss drainage.
Do you have a size threshold?
I was gonna say, and then we also have roughly, we'll have a size threshold of 5 centimeters.
Yeah, same.
So it kind of just depends. I'm sorry?
No,
Just
no.
aspirate? Just aspirate.
Aspirate.
I have unfortunately had to go into those abdomens before, and they are terrible. And you're
Same.
high risk for bowel injury. I mean, everything is just a mucky mess. And so there was one patient we ended up leaving a drain in, but she was a very specific outflow obstructive anomaly type setting. So that was a different situation.
I would say when it's greater than 5 centimeters, we touch base with IR when they're getting admitted to be like, hey, can you look at this? Do you think you can access it? Can you drain it? And sometimes they say, we don't think we have an access plane. So then I know if she's not getting better, I have to go into her belly, So it's kind of just nice to know up front what they're thinking, so that we have our next step if she's not getting better. But if they have a good site to drain it, I would say that they get better more quickly if you can drain it.
Thank you for coming, everyone.
Thank you.
We have 4 minutes before the next break shop in
Oh,
this
wow.
room. We'll have global surgery engagement. Thank you very much.
Thank you, guys.
Good job.